The 5-year survival is a mere 13% and has increased only 5% over the last 25 years. The most likely explanation is that most cancers present at a non-resectable stage. On a more optimistic note, stage 1 cancers, which account for less than 15% of cancers at presentation, have a much higher survival, reaching levels as high as 80%. With these statistics in mind, in the last couple of years, several lung cancer screening trials have been introduced. The aim of these studies is to determine whether indeed early detection of lung cancer, the identification of tiny nodules, will improve survival and decrease lung cancer-specific mortality. While it might seem obvious that if you detect a cancer while it's small, it should have a better prognosis, there are several confounding issues. First, as we've already noticed from the early results of some of the lung screening trials, some of the nodules that we detect are indolent cancers. They remain stable for many years and have no impact on the patient's survival. Other cancers, despite being tiny and undergoing surgical intervention, are biologically very aggressive tumours, and they will lead to a shortened survival that we have not altered despite our therapy and early detection. Until these issues are resolved, lung cancer screening is now not clinically recommended. Now, this is the sort of tumour that we'd like to identify. This is a stage 1 tumour, less than 3 centimetres in size, N0, M0, in a patient who's obviously a smoker with extensive emphysema. By CT, it's a spiculated mass, so we're fairly confident it's causing this likely to be malignancy. And on the PET image, we can see that there is avid uptake over the nodule, but no evidence of mediastinal involvement. This is a resectable early lung cancer. Now, as we found from our experience in the lung cancer project, as you find in clinical practice, many patients will have multiple nodules identified on any screening CT. These nodules are often tiny, some are calcified. If we see calcified nodules, we can be reassured that many of the other tiny nodules are also likely granuloma. But we're left not knowing what to do with these very small lesions. For the purpose of the studies, so they don't overcall the number of positive studies, both the National Lung Screening Trial and the LCAT study have decided that small lesions, either less than 4 millimetres or less than 5 millimetres in the LCAT study, should be followed up only at a 1-year interval. They made this decision for 2 reasons. Such tiny nodules are very difficult to measure, and interval growth is hard to determine. Also, many of them are going to be benign. Even if they do grow within that year's time, it's very unlikely to change the staging in that patient. So they have then decided, if you use this criteria, in all their patients screened, these are high-risk smoking patients, only 15% of the studies will be positive, and then the overall outcome is we'll pick up roughly 3% of lung cancers. These are the sort of lesions that you might see on a screening exam. We have the ground-glass abnormality in the right upper lobe. It's somewhat ill-defined. This is a class of lesions that now been described as semi- or sub-solid tumours. These tumours may be ground-glass alone, or they may be ground-glass with a solid component. This would be a good appearance for bronchoalveolar cell carcinoma. It would be also a good appearance for a pre-invasive form of adenocarcinoma that's been recently identified, that is seen in patients that have known VAC or known adenocarcinoma. But it also could due to inflammation. So what we recommend in patients, if the nodules are larger than 5 millimetres, that we should at least stick to our routine surveillance, where we do a scan at 3 months, 6 months, 12 months, and 1 year after that. And on this patient, when we did a follow-up at 3 months, it was entirely resolved. There's no way otherwise of differentiating apart from interval stability, whether this was malignancy or inflammation. Now, the tiny nodule at the left lung base, this is more problematic. It's more than 5 millimetres, so according to the lung screening trials, it counts as a positive study. But we don't know if this is cancer, so again, how do we follow it? Well, the early recommendations were you do a 3-month scan, but because it's so tiny, certainly in our clinical practice, we now tend to recommend do at least a 6-month follow-up, so we actually have a chance of detecting growth. As you can see from this diagram, a tiny nodule, a 4 millimetre nodule, even if it doubles in size, which is significant doubling, it will only increase to 5 millimetres. With a second doubling in size, it will only be 6 millimetres. And however obsessional you are with your measurements on CT, it's very hard to determine that sort of growth. even though it may suggest that this nodule is in fact tumour. At the moment in academic practice, but not in clinical practice, volumetry has been used to measure these nodules, and hopefully in the future this will become part of our routine evaluation of tiny lesions. Volumetry is also very useful in detecting uneven growth in irregular sized nodules, which is actually often a common characteristic of carcinomas. They don't necessarily grow in a uniform circumferential way, they often grow in a rather irregular way. Well, coming on to lung cancers, when we detected a nodule and we're trying to determine whether this is benign or malignant, the most exciting impact that we've had in imaging in the recent years is the introduction of PET, and in particular PET-CT imaging. And from the PET studies, we have determined that if we have a nodule that shows PET uptake, we can be fairly confident if the uptake is significant that this nodule is malignant, with a sensitivity of 94%. The specificity is somewhat lower because we have false positive lesions, as you know, granulomatous disease, in particular TB and sarcoid, or even other infections can be strongly positive on PET. Likewise, some tumours may be negative, so we have false negative studies, and in particular BAC and certain carcinoids can show minimal or no uptake. It's very important when you interpret a PET study to always look at the CT first. And on the CT, you want to make a pre-test probability judgment whether you think this is a tumour or not. And if you decide you think it's unlikely to be tumour and you go ahead and do a PET study and the PET study is negative, then it has a very high negative predictive value. If you think the tumour is very likely positive, but the PET study is negative or mild uptake, that doesn't necessarily deter you from calling this a cancer. So be very careful to always look at CT features. Probably the most interesting aspect of PET imaging is the staging. In the past, we have relied on size criteria for the staging of nodal disease in patients with known malignant nodules. And as you know from Dr. McLeod's work and others, the sensitivity and specificity of CT is really quite low. We use a cutoff of 1 centimetre, but we've all seen tiny nodes of cancer and large nodes be reactive. But as you can see, PET does much better. It has a sensitivity that approaches that of mediastinoscopy. It still is not the gold standard, and all surgeons still prefer to do a mediastinoscopy because what we're finding in PET, we are staging some patients as stage 1, no nodal involvement, but when they go to surgery, they find there are tiny foci of cancer within these nodes. And these foci are too small for us to pick up on PET. And until we have further long-term studies, we will not know whether these patients have a different outcome survival, as opposed to patients who have large volume tumour in their nodes. Okay, well I also want to show this image. This is an image to demonstrate how with PET we hopefully would avoid this issue. This patient's only 3 months out from a resection of what was called a stage 1 left upper lobe carcinoma. The changes on the left are all post-surgical. But now as you can see on the chest x-ray, at the region of an apical mass there is rib destruction. So this patient has now detectable metastatic disease on the 3-month post-op film. We went back to the pre-op film and there was an apical lesion, although the bone destruction was not as obvious. If a PET study had been performed, PET has a much higher sensitivity than bone scans in picking up bone metastases, approximately 70% as compared to 50%. So I show this study for 2 reasons. That PET improves our staging and improves the patient's surgical or chemotherapy planning, but also just to remind you that superior sulcus tumours, this is a MET, but if you have a primary superior sulcus tumour, the amount of opacity on the X-ray can be quite minimal, because as these tumours grow and they're soft tissue masses, they grow into the neck, and they blur with the margins of the surrounding soft tissue. So all that you see on the chest X-ray is often a small band of asymmetric density. So whenever you look at a chest X-ray, if you see apical pleural thickening, look to see if the sides are asymmetric. If it's asymmetric, nodular, more than a centimetre, you need to confirm stability or do further imaging to determine that this does not represent an apical tumour. Well, this is an example of where PET is at its strength. This was a patient who had a lung nodule that was suspicious for malignancy, and it certainly was hot on the PET study. And by CT staging, there's no evidence of lymphadenopathy. It was called stage 1, M0. But you can see on the PET study there is uptake in the perihilar region that would correspond to this area, just about the prevascular perihilar area. So by PET staging, this patient was at least a stage 2, possibly stage 3, because it's sort of AP window node. So this patient's now been given the prognosis that initially would have been around about 80% and can drop down as low as 40%. Now this is an example of a negative PET, and as I pointed out to you earlier, if the nodule looks like malignancy, don't allow the PET to distract you. This is a nodule that has all the classic features of BAC. It's got some bubbly lucency, pleural tags, which are a concerning sign for adenocarcinomas or BAC. So if you see the PET study, you could call it PET negative or minor uptake, but you're still concerned about BAC. If you're not 100% convinced this is tumour and it may be inflammation, then the way to follow is serial CTs. This is an example of how you can make a pretest probability from CT that this is unlikely to be malignant. This is a somewhat oval lesion. It was a little bit rounded, so there's some concern about tumour. Allowing for the difference and the uptake compared to background, this was actually only mild to moderate activity. And so with the combination of CT features, the PET study, this was called negative for tumour. And therefore, on these sort of patients, we would be fairly confident in saying the patient, this is a high predictive negative study, that we would just follow by CT to resolution. Okay, marching on now to lung nodules, there's a seminal paper by Austin from Radiology that's quite disturbing. It shows that even experienced board-certified radiologists will miss cancers up to 3 centimetres in size. The majority of their missed cancers were 1.5 centimetres in size. They were in the upper lobes, where we expect cancers to be. They were more commonly missed in the right upper lobe, but again, cancers tend to be more common in the right upper lobe. And the ones that were typically missed, as you might expect, are around the bony confluence or around vascular areas. Many of the missed cancers were identified more commonly in women than men. There's no obvious explanation, but a word of warning: when you have women presenting for a chest x-ray and they deny that they're smokers, it's very important, if you think there's a nodule, for further evaluation to determine have they ever smoked in their late teenage years or early adulthood. Unfortunately, data is coming through that women are more susceptible to lung cancer than men. This may be hormonal, and they particularly seem to be susceptible to lung cancer if they've smoked in those critical years. So to the woman who's now 60 or 70 years old, they say they've never been a smoker, but go back and ask if you're suspicious about a nodule, had they smoked in their late teens? Now, what Austin also showed in his studies that many of the missed nodules were posterior. And we often don't see nodules very well in this portion of the X-ray. However, what he did notice that only a couple of lesions were seen only on the lateral view. And this is why on the lung screening trials, if you're randomized to chest X-ray alone as opposed to CT, you only get a frontal view. His explanation for why lesions were missed: the most common cause was the lesions were obscured, but usually the reason they were missed was because they were ill-defined. Some cancers are very ill-defined, of hazy density, and they're hard to see. And the recommendation from that study was to try and identify these cancers. It's important to look at the prior X-ray, not just the X-ray you have before this presentation, but the earliest X-ray you have. And anybody who's a PAC system has the opportunity to look at X-rays 2, 3, 10 years back. Probably 10 years optimistic, 5 years back. And if you look back at the earliest films, you can often detect a subtle abnormality. And that's his strongest recommendation. Good radiologists will miss lesions, but if you... So lesions can be... We can miss them because we're distracted, either people are chatting in the room, or we find some other abnormality that distracts us and we finish looking at the X-ray. Or, as I mentioned, they're inconspicuous. This is an example of a nodule that is 2 centimetres in size and somewhat obscured by the clavicle, anterior and posterior ribs. This is a larger mass, which to me seems fairly obvious, but when I've shown it to people before, many trainees will miss the fact that there's a large lesion in the region of the AP window. They look at the hilar, they notice the density of the hilar, but they don't notice that this normal concavity, where you should have normal aerated lung, has been obscured. So my message to the residents, but anybody in practice, when you finish looking at the lungs for nodules, very carefully look at mediastinal contours, and in particular around the aortic knob. Make sure there's not a double contour or filling in of the AP window. I've seen a number of medical legal cases where the tumours are really quite big like this, but were missed because we forgot to look at the mediastinum. However, you shouldn't really miss this on the lateral view. The mass is really quite large. Again, I say to residents, if they're looking at lateral view and they're finding it somewhat confusing, if you've always looked in the sternal region, behind the heart, and then also ensured that you have increased transradancy as you go down the spine, you won't miss many lesions. So every time you're presented with a lateral view, whether it's in the board exam or in real life, always look in these three areas. Now this is an example of satisfaction search where you can be distracted. This patient has a pacemaker, unusual location. It's going down the left superior vena cava, and while you're fascinated by the course of this pacemaker, you've missed the nodule, which is in an area of bony confluence. This is an example of an inconspicuous nodule. This patient fortuitously had a shoulder X-ray for shoulder pain. And the orthopedic radiologist did an amazing job. He picked up in the corner of the film, there was the density. This X-ray was taken after the shoulder view, and try as I might, it was incredibly difficult to determine any sort of increased opacity in that area. However, CT confirmed that the orthopedic radiologist was better than I was, and there is a mass that conforms to a BAC. Again, the telltale signs of cancer, pleural tags, distortion of the fissure. A word of warning about any lesions that are ill-defined that you think might potentially be BAC. 2 years stability is not enough. A recent review of the seminal paper in 1958, which looked at how long we should follow a nodule before we could be confident it was benign, has only specificity of 68%. So what I recommend, if a lesion looks like it may be a BAC, you need to follow it for longer. This nodule was followed for 4 years before it's taken out. If you look at the last 2 years, there's been some minimal increase in density, but not much increase in size. If you went back to the earliest film, it's clearly larger. The initial mistake by a radiologist, they didn't notice the interval change between these two, but clearly there's a difference between the first and last. So what I would like you to do is when you're reviewing your CTs, you're following up nodules, always go back to the earliest film, and in doing so, in this case, it's quite clear that this nodule has grown. Fortunately, if the patient is a BAC and there's no change in staging. But what else can we do about nodules? We can try and decide if they're benign, if they're calcified and smooth, if we see spiculation, pleural tails, positive bronchus sign. We're fairly confident they may be malignant. However, if we see a satellite lesions, that is, we see a dominant nodule surrounded by smaller nodules, somewhat irregular, this is a telltale sign suggesting this is probably a benign lesion and likely granulomatous disease. So look at the pattern and the shape and the contours of the nodule. Now, you've heard in earlier talks, sometimes the mass presents in a cavity. Conventional teaching is the cavities tend to be thin-walled infection, thick-walled in tumour. This is not a very specific sign. And as you see in this case, this was a young man in his 20s who had a lung abscess, who had already had antibiotics, hence the surrounding pneumonia had resolved, but the lung abscess remained. The patient you saw in Dr. Quino's talk, who has neutropenia covering, so we now get nodular mass with surrounding ground glass. There's some of the abscess infection. Anytime you have a nodular cavity, the information you can have is the prior radiograph. If this nodule wasn't present a few weeks ago, you know it's infection. This is an example of a granulomatous disease, in this case tuberculosis, where we have a dominant lesion with multiple nodules surrounding it. These are the satellite nodules. If you see this pattern, you should be suspicious that it's a benign entity. Don't do a PET. It's very positive in granulomatous disease. You want to do either an invasive test, a bronchoscopy, or possibly even a fine needle. This is the positive bronchus sign, where you see a bronchus leading to and cut off by the mass, a feature of adenocarcinoma. Now, we can also look at calcification. If the lesion is densely calcified, as in this case, we know it's a granuloma. If it's got calcification that is somewhat irregular and maybe a little bit chunky, somewhat popcorn-like, we can be suspicious it's a hamartoma. And if the CT confirms that there's also fat in the lesion, we can be very confident it's a hamartoma. Unfortunately, only 25% of hamartomas have calcification. So the most reliable sign is the detection of fat, which may be generalized or focal. In these lesions, if you just try and follow them for stability, if you're unsure whether they're benign or malignant, you can be confused because hamartomas can grow. So the best way of making the diagnosis is identifying the fat within the lesion. This patient had a calcified nodule, but if you look on the soft tissue windows, the calcification is eccentric. Therefore, don't interpret this as a calcified granuloma. There is a soft tissue mass lateral to it, which happened to be an adenocarcinoma engulfing a granuloma. So the calcification should be within the body of the nodule. This is an example of a calcified metastasis. I show this case because we recently had a very interesting paper from the Brigham where the surgeons reviewed the likelihood of a solitary pulmonary nodule being malignant in patients with a prior lung cancer or a prior extrapulmonary malignancy. If you had a prior lung cancer or a prior extrapulmonary malignancy, the solitary nodule was very likely to be malignant. In the patients with prior lung cancer, the solitary nodule was very likely to be a second lung cancer. If you had a prior extrapulmonary malignancy, the nodule was then very likely to be metastases. And just to remind you, some metastases are calcified. So if the patient has a history of sarcoma and you have a calcified nodule, this could be a sarcoma metastasis. So follow these on serial CTs to make sure they're not enlarging. And I'll just quickly go over a few diagnostic dilemmas that we've had since our introduction of PET. This was a patient that was somewhat perplexing. She was known to have sarcoidosis, and these nodules do very well for sarcoid. They're in clusters, they're along the bronchovascular bundles, and they're upper lobe predominant. She also had nodes. This clinician was worried because a nodule that was rounded and a different character had increased in size. The woman was well, so what should she do? She did a PET, hoping to see whether the low lobe nodule lit up. Well, to her horror, the woman was labelled as widespread metastatic disease. The person report didn't appreciate the fact the woman had sarcoidosis, and of course sarcoid can have the hottest nodules in the world and the hottest nodes. So these are sarcoid nodes. They were subsequently biopsied to confirm that by a Wang procedure. The nodules were also all likely sarcoid, although unfortunately we can't differentiate with that nodule, a different character was the same process. But what was even more horrifying, she had uptake in the spine with no CT correlate. So now we're left with a healthy woman. Does she have bone metastases and sarcoid elsewhere? Well, there was nothing to biopsy, so it was decided because she was well, the probability was that this was all sarcoid, but unexpected sarcoid in her bones. This is another interesting example that when you review PET, this is a patient with mesothelioma, but make sure that when you call uptake in other parts of the body outside the primary site, don't call it metastatic disease if the pattern of uptake would be unusual for disease spread. This was a very localized mesothelioma, resectable, but she had this pronounced uptake in the abdomen. There was no CT correlate. The surgeon said, this can't be disseminated nodal disease. She doesn't have any nodes on the left side of the chest, maybe a little bit of activity on the right. How could this be a node from sarcoid? They ignored us. They went to surgery, which was the right thing to do. It turned out that node on operation was a sarcoid node. This woman had no history of sarcoid. So if you get a disease pattern on the PET that seems atypical for metastatic disease in that tumour, think of other differentials. And another example of sarcoid confusing a picture in a patient with metastatic disease. This was one of her PET studies involved in her management. These nodes were due to sarcoid. This uptake in her femur was an unexpected bone metastasis. So just to show you, PET studies are excellent, but you need to use some common sense and you need to use your CT. And then finally, the last part of the lung cancer nodule talk, I'd like to introduce radiofrequency ablation. It's a very exciting new procedure, so for those of you who like challenges, anybody who's developed the skills from fine needle aspiration can have the skills for radiofrequency ablation. You use larger probes, the risk of pneumothorax is higher, but the pneumothorax can be managed. And we use radiofrequency ablation to destroy nodules in patients with usually disseminated disease where we want local control. This was a young lady who was inoperable metastatic disease. This was her nodule. And this was the post-ablation picture many months later where we have a cystic lesion that's larger than the original nodule, which is the ideal appearance. We want to burn the tumor out, but also destroy some tissue around the tumor so we have a safe margin. What she does have, however, is a little nubbins of soft tissue here, and it's not entirely clear whether this was just a maculated cyst scarring or residual tumor. The way we try and differentiate on ablation studies is to do follow-up studies with contrast. And if this is the residual tumor, sometimes this will enhance, so we can look at the enhancement pattern to differentiate. In this case, it didn't enhance, so the way they were following it was just by serial CTs. But this is the ideal situation, with at least 90% destruction of tumor. We don't always go for 100%, we try and debulk. These are the complications. They usually have a post-ablation syndrome associated with effusion and fever, but that resolves fairly rapidly. And this is an example of a patient that had radiofrequency ablation for pain control. We knew we weren't going to destroy all this tumor. This is the destroyed portion of tumor. She still has a mass around it. but the tumour was smaller and her pain was better controlled. So patients who have uncontrolled pain, radiofrequency ablation is an alternative management. Okay, I'll take a little breath and then I'm going to talk about thymic lesions. I decided rather than do a laundry list of mediastinal lesions, I'd concentrate on just one topic. And I chose thymic lesions because they are the most common cause of lesions in the anterior mediastinum. They also have a very interesting association with autoimmune diseases, in particular myasthenia gravis. So thymic lesions, the most common thymic lesion is a thymoma. They can occur anywhere in the mediastinum. They typically are anterior superior, but they can be anywhere along the length of the mediastinum and anywhere along the length of the cardiac silhouette. They can be moderately small, they can be very large, or they can only be sometimes defined on CT. At least 25% won't be visible on the chest X-ray. The typical appearance of a thymoma, it's a smooth heterogeneous mass, usually well defined, often completely surrounded by fat, with lobulation. Some of them will have calcification necrosis, but it's not a major feature. This is an example of a very typical soft tissue thymoma. The growth is usually asymmetric. We have the lobulation and we have the fat. There are no features on this test, it's invasive. Although this is the limitation of CT. We can detect thymomas, but we're not very good at differentiating non-invasive thymomas from invasive thymomas unless we see metastatic disease. Differentiation is usually only made at pathology where they determine that there's invasion of the capsule. This is an example of, again, a non-invasive thymoma that's showing some of these tumours really enhance quite markedly with contrast. So contrast enhancement doesn't help to differentiate between invasive tumours and non-invasive tumours. It's just a feature of thymoma. So although it's disappointing that we can't distinguish between the two, we can at least look for signs that might be suggestive. So invasion of the local vascular structures. Blurring of the fat around the tumour can be seen with benign lesions as well as invasive lesions. Loss of fat interface between the tumour and the vessels does not mean invasion. You really have to see true through-wall thickness. But a good sign that there's invasion if you see irregularities, the contour of the pleura, involvement of the lung, or if we see metastasis. And thymoma is a very interesting lesion. When it metastasizes to the pleural space. It is confined within the thorax, usually to one hemithorax. Now this is an example of an invasive thymoma, and there are no features particularly to help us determine this, except that it is rather large and ugly looking, and it seems to extend and cause some compression of the superior vena cava. However, any large mass could do that. It also has obliterated the fat interface between the aorta and the tumour, but again, a benign, non-invasive thymoma can do that. So if we don't identify nodes or pleural disease, then the differentiation is made at surgery. And not to confuse you, but another common cause, an anterior mediastinal mass, which can look identical, if I go back, to the invasive thymoma or a non-invasive thymoma, is Hodgkin's lymphoma. Now we usually differentiate because of the age of the patient. Thymomas are much more common in the older age group, while Hodgkin's lymphoma is more common in the younger age group. Symptomology may also help. Otherwise, the lesions look identical. They're lobulated, they may have necrosis. They don't usually have calcification unless the Hodgkin's lymphoma is being treated. But what might help us, these patients often also have local or generalized lymphadenopathy. Well, if we see pleural disease, as we do in this case, we know the patient's got an invasive tumor. And as I described, the pleural disease is usually confined to one hemithorax. It may be focal nodularity, more diffuse thickening, or it may be very nodular and form a circumferential rind and be indistinguishable from mesothelioma or adenocarcinoma, typically from breast or lung. But in this patient, when you have the combination of a pleural nodule and a large anterior mediastinal mass, then you should be suspicious that this is thymic in origin. Now, has PET studies helped in thymoma? Not particularly. If you do a PET study in a patient with a thymoma, you would have uptake. The standard uptake values are reported in the range of 3, 3.5, and there's no differentiation between patients with invasive and non-invasive thymoma. However, we can differentiate thymic carcinoma from thymoma because typically the uptake in a thymic carcinoma is much higher. So there is some role to play in PET imaging and thymic lesions, but it's fairly limited. What is the survival? Well, if you have an encapsulated thymoma, you have a much better prognosis than invasive thymoma. But if you are reading CTs, these patients, do remember that you can get recurrent disease even in the encapsulated form, and that occurs in up to 12%. Well, coming on to myasthenia gravis, it's a fascinating disease. As you know, it can be ocular only or generalized disease, and there's a common association with thymic abnormalities. And the most frequent finding is of lymphoid hyperplasia rather than thymoma. The overall statistics are that a third of patients with thymoma will have myasthenia gravis. What is interesting, the appearance of the thymoma or the appearance of the myasthenia may not be synchronous. So the tumor may appear before the myasthenia or after the myasthenia. The reason that we scan these patients is because the patients will get the best response to treatment by surgical management. So we scan the patients to try and identify whether they have a thymic lesion. And if these thymic lesions are removed, many patients get complete or at least partial remission. Recent studies have shown that if you have lymphoid hyperplasia at histology, you usually have a better response and better remission than if you have a thymoma. Younger patients and female do better than older patients. And if the surgery follows shortly after developing symptoms, they seem to also have a better prognosis. So if the diagnosis is detected early, the outlook is better. There are other autoimmune syndromes that are associated with thymic lesions. We have red cell aplasia and hypogammaglobulinemia. In red cell aplasia, patients only usually get a minor response or improvement following thymectomy. And in hypogammaglobulinemia, there is no benefit. So what does follicular thymic hyperplasia look like? Well, it has a varied appearance, but in the majority of lesions, the thymus appears normal. It's only detected at surgery. So you will have surgeons that will go do the CT in a patient with myasthenia. The CT will be reported as normal, but they will still go and operate and remove thymic tissue because there may be lymphoid follicular involvement. The diffuse enlargement of the thymus often is in a thymus that has maintained the normal bilobed shape. Or you may have an anterior mediastinal mass that looks identical to thymoma. Fortunately for us, we don't have to worry too much about differentiating between thymoma and the hyperplasia because the surgeon will remove the thymus regardless. Now, some people have tried doing PET imaging on thymic hyperplasia. In this patient, you can see the enlargement of the thymus, but it's still maintained the bilobed appearance. It's somewhat dense for the patient's age. Of course, whenever you interpret a thymic lesion, look at the patient's age, because you know when they're young, particularly in their 20s, they will still have nodular soft tissue. Fortunately, myasthenia doesn't usually occur in this age range, and thymomas usually occur in the older age range. But by the time you get to 40, the thymus should be almost completely fatty replaced. So you shouldn't have this nodularity. The PET study was done, and it was PET negative. So although I mentioned that PET doesn't differentiate the different types of thymoma, in some studies you could be more confident saying this is more likely to be hyperplasia than thymoma, but this is more on an anecdotal basis, and there's really not much literature there, so we're just making observations on our PET and collecting data. Now, the sort of hyperplasia you've probably seen more often, particularly if you work in a cancer institute, is in the young patient who's on treatment for chemotherapy and they get rebound enlargement of their thymus. The patients that are most likely to get a rebound are young, as I've mentioned, but also patients that have a prior history of lymphoma, a prior history of sarcoma, or a prior history of germ cell tumors. When these thymic lesions enlarge, the thymic composition remains normal, as opposed to the lymphoid hyperplasia that you get in myasthenia gravis. And the appearance is usually just of an enlarged thymus, where you still see fat stranding through the thymus, because these are usually young patients, and you still have the normal cell-shaped bilobed configuration of the thymus. However, in some patients it's confusing because the thymus enlarges but becomes increased density and increased nodularity. Now, in this patient, on chemotherapy, the thymus maintained the triangular shape and maintained the density, but just got larger. So the clinicians were fairly comfortable, as this patient was on chemotherapy and it occurred within a year of the treatment, that this was thymic hyperplasia and it would be followed. Typically, the Rebound hyperplasia occurs within a year of therapy. However, it can persist for longer, and it can also appear as a late event, up to 5 years later. So it can make the differential diagnosis from CT really quite difficult. And I show you this case because this is exactly the sort of situation where we're perplexed. This was a young woman with Burkitt's lymphoma who was on chemotherapy. She had multiple nodal involvement. And on CT follow-up, the majority of the nodes were decreasing in size, suggesting a good response to treatment. But in the intervening time, she developed a mass within the mediastinum. The mass was somewhat rounded. It wasn't clearly multifocal and nodular, but it had increased in size and had increased in density. So what were we going to do? Was this rebound hyperplasia, because the rest of her disease was resolving, or did she have a new-sited tumour? Well, we tried doing a PET study, and the PET showed mild to moderate uptake, so that was reported as rebound. They also requested a gallium study. The gallium study showed mild to moderate uptake, and that was reported as tumour. So we're left really not knowing what to do, because it's well reported that rebound hyperplasia can be positive on gallium, and it can be positive on PET. So if there are any features that are concerning, multiple lobulations, rapid increase in change in density, then our only alternative after that is really biopsy. Then going on to thymic cysts as a follow-on from talking about Hodgkin's, thymic cysts are most commonly seen post-radiation treatment. They may be congenital and they may be associated with other thymic tumours. The typical appearance is just of a thin-walled cyst, so no nodularity, no septations, occasional calcification. And this is an example of a simple thymic cyst without complication. We just have a well-defined cystic mass in the anterior mediastinum that's actually quite large and extends down the right side of the mediastinum. These cysts are often frequently removed because they can have a hemorrhage into them, which causes a decrease in size and sharp chest pains, or just because of size, they will gradually grow and may cause mass effect due to the size phenomenon. Also, many surgeons aren't comfortable leaving a thymic cyst alone, although the majority, when they look like this, are going to be benign. You can't be absolutely sure that there's not a tiny focus of tumour within the wall. So these tend to be resected. Going on to thymic carcinoma, this is a rare, very aggressive tumour. It typically is in the older population. The majority of them are symptomatic. With thymomas, at least half patients are usually asymptomatic, and it's an incidental finding. In these symptomatic patients, again, over half of them will have metastases at presentation. And unlike thymoma, the metastases are not confined to the pleural space. There are widespread hematogenous and lymphatic metastases, and the prognosis is dreadful. The appearance of the carcinoma relies, the differential and the diagnosis relies on the determination of the local invasion and the metastatic disease. The tumours themselves can be very large. They can have areas of necrosis and hemorrhage, but as I pointed out earlier, you can see necrosis in thymomas. So the important finding is the finding of distant or local invasive disease. And this was an unfortunate patient who broke many of the rules. She was young, in her 20s. She was female. She had a cough for over a year. She was distracted by exams, so she presented after she completed her finals. And we have this very complex lesion in her mediastinum. The superior portion looks like a normal thymic cyst. It's fluid density with a thin wall, but as you come lower and posteriorly, you see there's some irregularity. And then unfortunately, as you get even further into the mediastinum, we see there's this very irregular soft tissue mass. And at surgery, this turned out to be an aggressive thymic carcinoma. It was mixed tumor type, it was squamous adenocarcinoma, and it was arising from what was thought to be a congenital thymic cyst. Now, what we often see in younger patients is this sort of lesion that has some of the features. It has fluid, it has soft tissue, but we make the diagnosis because we see fat. We don't see fat in thymic carcinomas. There is one thymic lesion where you see fat, thymolipoma, and I'll show you a picture of that. It doesn't look anything like this. So whenever you see an anterior mediastinal mass and you have a fluid density and you have a soft tissue density, look to see if you have fat to determine whether this is a teratoma. Thymic carcinoids. These are really nasty tumours. They're thought to be a subset of thymic carcinoma because they often do present with metastases. These are interesting tumours because the diagnosis can often be made from the clinical information. Majority of these tumours are metabolically active, often with ectopic ACTH production. So if a patient presents with Cushing's syndrome and you have a thymic lesion, it's very likely to be a thymic carcinoid. Interestingly enough, these patients do not develop carcinoid syndrome. They have Cushing's syndrome. There is also an association with multiple endocrine neoplasia. These lesions can be extremely large, as in this patient. There was a large mass flowing along the length of the mediastinum, and you can see this patient already has quite extensive pleural metastases. On the chest X-ray alone, without the information of whether this is metabolically active, this would still be a good appearance, maybe for a lung cancer with pleural metastases, or possibly even a mesothelioma, because it's somewhat circumferential in its distribution. But if you do the CT and you see that the predominant finding is of a large mass, unfortunately this is lung windows, but it shows that there's this large irregular mass, calcification is present within the lesion, and we have the pleural abnormality due to the metastatic disease. So this is almost an arm mini. If you find the patient has ectopic ACTH, thymic mass, think thymic carcinoid. Thymolipomas. These are quite dramatic lesions. They can be extremely large. They're very soft and very pliable, so they tend to flow along the diaphragmatic contours, and they can actually change shape and change in position of the patient. The appearance is characteristic. On plain film, this is a copy image, I'm afraid, but it shows that you've got this opacity that's flowing along and obscuring the diaphragm. Without a CT evaluation, maybe you'd think this was atelectasis, but if you look on the lateral view, there's no evidence of lower lobe atelectasis. Is it some sort of pericardial cyst? Well, it's got a somewhat unusual configuration. On the lateral view, it's very hard to define. It could possibly be an elevated diaphragm, although it does seem to peak rather sharply. So the appearance is really only made on CT, and this is the characteristic appearance. The lesion is nearly almost entirely fat. But within the fat, we have these swirls and whirls of thymic tissue, with nodular thymic tissue throughout. This is a different patient, but just to show how extremely large it can be, this tumour occupied the whole of the left hemithorax and most of the right hemithorax. These are benign lesions. If you see this in the exam, it's a nice arm mini. There aren't really other tumours that look like this. Just to show you another fatty tumour that came through our service that was really quite bizarre. This patient was noticed to have an unusual cardiac silhouette. It wasn't thought to be cardiomegaly, and that on the lateral view, it didn't appear to be a mass that was posterior. The opacity seemed to overlie the region of the cardiac silhouette, so we weren't sure, was this pericardial in origin? Was it an adjacent mass? So on the CT, you can see on this coronal reconstruction that the mass is completely fat. There's no swirls or whirls in it like the other lesions, so it's not a thymic lipoma. And in fact, on serial images, if you follow it through, it's contained within the pericardium. This was a very large pericardial lipoma. But just to show you, other fatty lesions in the mediastinum don't tend to have these nodular remnants within them. The differential diagnosis of a large fatty mass is lipomatosis, focal lipoma, and then very, very rarely liposarcoma. So in conclusion, what I'd like to bring home to you, that it doesn't matter what imaging modality you use, you need to carefully evaluate the technique, try and get as much clinical information as you can, and probably the best advice I have, look at as much of the prior imaging information that you have. With regards to chest X-ray, look back to the earliest film. Because not to unnerve you, but the second most common cause of medical legal action in radiology is missed lung cancers. And the majority of those missed lung cancers are on the chest radiograph. And then for those of you, I'm into my second year now, PET-CT, my best advice is characterize the lesion on CT first, then look at PET. So in your mind, determine a probability of the likelihood of malignancy. Don't allow the PET to fool you, and if the PET appears to show a surprising appearance, try and think out of the box. Could it represent some other process? And then my last word of advice is, we can be the best radiologists in the world, but if we don't communicate with the clinician, we can run into trouble. So thank you for your attention.
Wood, Assistant Professor of Radiology and Co-Chair of Cardiovascular Imaging at the Rebound Medical School, and he'll be speaking to us this morning on acquired heart disease.
Thanks. So before we get started, can you all hear me back there? Okay. Before we get started, I want to let you know that the slides that you're going to see are slightly different than the slides that are in your notes pages. And so I have an email address down here. Take a second to copy that email address. I will send you the slides that you're going to see, as well as additional notes. If you just email that address before April 12th, we can send one large bulk emailing so that you'll have all the information that you need. I do know what you want, and I will give it to you. You just need to let me know your email address so you can get that information. So what we're going to do is talk about cardiac anatomy and talk about how important it is to know the anatomy to understand what the pathology is. We're going to talk about abnormal myocardium and pericardium, spend some time on acquired valve disease, and show some coronary artery disease. In terms of the plain film anatomy, you need to know the locations of the chambers on the frontal radiograph, the right atrium being border forming and the left ventricle being border forming on the left side. On the lateral radiographs, the right ventricle being anterior, the left atrium being posterior. This is an example of regular PA radiograph. You see the confluence of the superior vena cava. The superior vena cava dumps into the right atrium. That's a right border forming structure. The right atrium dumps into the right ventricle. You don't see the right ventricle on the frontal radiograph. It's anteriorly located, but you certainly do see the pulmonary outflow tract located just below the aorta, which then comes into the left atrium, again central, but instead of anterior being posterior in location, and then dumping into the left ventricle, which is border forming on the left. So really understanding where your chambers are going to be, it's going to be critical for you in terms of understanding the pathology. This is obviously the aortic outflow tract in red. Similarly, I want you to understand where the normal position of the valves are. You can't tell what valve's what unless you know where it is. This is the tricuspid valve. On the right side of the heart, the mitral valve is central, and it's going from front to back. Location of the aortic valve along the left ventricular outflow tract, and the pulmonic valve also central along the right ventricular outflow tract. So normal locations of the valve in the frontal radiograph. On the lateral radiograph, we're going to do the exact same thing. You need to know where the SVC is. The SVC dumps into the right atrium, not border forming on the lateral radiograph, but the right ventricle certainly is. It's the most anterior chamber. It goes into the right ventricular outflow tract and dumps back into the left atrium. Left atrium, the most posterior chamber, which goes to the left ventricle. And remember, the left ventricle actually forms the inferior border of the heart. Almost all of it is through as you go out. And this dumps into the aortic outflow tract. And I want to draw attention to this pink line. It's a diagonal line on the lateral radiograph. It's extremely useful for learning where the valve is and knowing where valve replacements are and valve calcifications. The mitral valve is inferior to this line. Remember that fact. It might help you in a hotel room one day. The aortic valve is superior to that line. So you can separate aortic and mitral valve pathology based on this simple measurement of just drawing a diagonal line through the heart of the radiograph. The tricuspid valve, it goes through the line. And the pulmonic valve is probably the easiest one to see because it's the highest one and it goes right along the right ventricular outflow tract. In CT, obviously it's the same anatomy. You just see things a little bit better on these superior cuts. Another key thing to remember, aortic root is always in the center of the heart. You get nervous, you don't know where you are. The aortic root's in the center. The right atrium, border forming on the right. The right ventricular outflow tract forms the anterior border of the heart on these images. The left atrium forms the posterior border of the heart on all images that you see in the left ventricle, the left border of the heart. Moving to some lower cuts, you have the right ventricle. The right ventricle is located right behind the sternum. It's the most anterior chamber. Sounds simple, but how useful it can be. Left ventricle, it's inferior and it forms the left border. And the right atrium forms the right heart border. Okay, let's talk a little bit about coronary anatomy. You're going to need to know a little bit about coronary anatomy, and don't start writing things down crazily because this is the first of those notes that aren't there. You're going to get all of it, don't worry. From the left sinus comes the left main coronary artery. The left main coronary artery divides into the left anterior descending and the left circumflex artery. This is the left anterior descending artery. The branches that come off of the LAD are the diagonal branches. By the way, the branches that come off the circumflex are the obtuse marginals. Here you see on the next cut the origin of the right coronary artery. It occurs slightly inferior to the origin of the left main. This is the right main coronary artery. This is the left anterior descending. That's the diagonal branch, and that's the circumflex. You see them all around the heart as you move from superior to inferior. Again, right main coronary artery, left anterior descending artery. This is that diagonal branch, and you see the circumflex as you move right main coronary artery, LAD, and you see the circumflex. This is the coronary sinus. The coronary sinus is the draining vein which drains into the right atrium, and this tiny branch down here which comes off of the right coronary artery is the posterior descending artery in most patients. When the posterior descending artery arises off the right side, it's a right dominant arterial system. Okay? Coronary artery anatomy, very important to know nowadays that we radiologists are imaging coronaries. In MR, again, the anatomy is the same. You can see static or cine images. When you see, I have this in quotes, when you say a cine image and you happen to be in a hotel room, you say the words steady state free precession, because that's the pulse sequence that made that cine image. And you can go miles and miles by just saying that is simple words. And so when you see a cine image, you say it's a steady state free precession image. This is anatomy on MR. Coronal plane, you see the aorta coming down. In red, same thing, the pulmonary artery. This is the AP window between the aorta and the pulmonary artery. As I'm sure you know, the left atrium posteriorly located and central. Left ventricle, left border forming, just like it was in all the other modalities. No surprise, you see the IVC on this large field of view coronal image. Mitral valve between the atrium and the ventricle. Now we're moving a little more anteriorly. You see right atrium, this is the SVC dumping into the right atrium. The right ventricle kind of in this gray color, the pulmonary artery again. And you see the left ventricle, border forming on the left. Aortic outflow tract, and you see the aortic valve, where it's supposed to be, between the left ventricle and the aortic outflow tract. Tricuspid valve between the atrium and the ventricle on the right, and you see the Pulmonary valve along the right ventricular outflow tract. So that's basic anatomy for you to see. A basic cine image so that you've seen one. This is a 4-chamber cine steady state free precession. How easy it is to see. 4 chambers. If you see one of these images and you get lost, there's no reason to think that you're lost. If you look at the images, the left atrium is the most posterior chamber. It always will be, no matter what orientation you have. That makes this the left atrium, that makes this the left ventricle, right atrium, right ventricle. It's called 4 chambers because you actually see all 4 chambers on that MR image. Let's talk about abnormal myocardium. Differentials in acquired cardiac disease aren't that complicated. They're kind of easy differentials. You have infarction, hypertrophy, masses, infiltration. This is another MR image. This is a cine steady state free precession image because they all are. It's a 2-chamber view. This is the left atrium, this is the left ventricle. You can see here that this is much different than the normal image that you saw. And the reason is because the myocardium that you saw doesn't exist here at the apex. It's completely thin, and this myocardium is not beating. It's hypokinetic, or less than normal kinesis at the base, and at the apex it's akinetic, or completely not beating. And so this is a post-infarct myocardial thinning with hypo and akinesis. A patient that's had an MI. You look and you see that the apex of the heart is now projecting over the abdomen. That's not normal. The apex of the heart should not be that low. You look on the lateral radiograph, and you see these calcifications. When you see calcifications in a patient with a large ventricle, there really can only be so many different places. But when you see them in the location that you expect the left ventricle to be, you can suggest that the patient has a left ventricular aneurysm. A favorite hotel diagnosis. You look at the next case, a 50-year-old status post-MI. You imagine what the normal left ventricle will look like. The normal left ventricle looks like that. There's a gigantic contour abnormality. There's a contour abnormality in the frontal radiograph. Contour abnormality in the lateral radiograph. You can suggest that a CT, but you already know, the patient that's had an MI, you do the CT, you see 3 chambers. Obviously, one of those chambers doesn't belong there. That's the chamber that doesn't belong there. This is an axial MR, a static MR. Don't say steady state free precession if you're looking at a static image on MR. That won't bode very well. But you can see it on a sagittal view, another example of a left ventricular aneurysm. Because it's so popular, I'm going to show it to you every single thing. Again, a sitting steady state free precession. This is normal myocardium up here. This is a gigantic inferior wall down into the abdomen. Another case that you've seen in every different possible configuration of a left ventricular aneurysm. Okay, let's talk about hypertrophy. Hypertrophy alone, not visible on chest, to have some abnormality in a cardiac chamber or some calcification to actually see it on a chest hypertensive disease, usually or changes. You look at this patient, it's enlarged on a radiograph. You can imagine what the aortic contour is. It's very enlarged. Play it, show it one more time. Typical changes. And then what the pink line is in each case when you're looking at a radiograph and you're thinking it's a heart case, even if it's a PD heart case, imagine what normal looks like. If you just imagine what normal looks like from your experience, you start to think of what's abnormal. If normal is in pink, you can start to think, hey, this is abnormal along the border of the left ventricle. And this is a patient with left ventricular enlargement and tortuous aorta, just a simple case of hypertension. You can shoot as many radiographs as you want, but you'll never make a diagnosis until you use an advanced modality. This is a patient that has a massively thickened, this is actually the septum up here, a massively thickened left ventricle. It's asymmetrically thickened, it's more thick along the septum, an example of hypertrophic obstructive cardiomyopathy, another hotel favorite. Myocardial tumors. Mets, much more common than primary, that's always the case in the heart. You got your normal list of players that are going to cause metastasis. But there are some myocardial tumors that you can easily identify and you will have to identify. If you see fat like this, splayed between the left atrium and the right atrium, and that's diffuse, it's not well circumscribed. That's lipomatous hypertrophy of the intraatrial septum. That septum is being hypertrophied and it's entirely fat. It's a benign diagnosis that you're going to need to make. If you see, this is a different case, this is a lesion in exactly that same location. This is a mass, and it's very well circumscribed, as you see. You look on this MR, this is a T1 pre-fat sat and post-fat sat. You see that this is the fat, and the fat's completely satted out, so the mass is entirely fat. This is a cardiac lipoma. The difference between lipomatous hypertrophy and cardiac lipomas are these are well circumscribed, but they're both fat-containing. They're both easy to make the diagnosis, and it's a diagnosis you have to make. You can't just say, there's a mass in between in between the intraatrial septum. You need to know what that diagnosis is. This is a patient with breast cancer that you can tell from the reconstructive surgery. When you see a contour abnormality in a patient that you know from another finding or some history has a malignancy, you think about a metastasis. There's the abnormal lesion here. World's oldest MRI shows the abnormal lesion here. This is a metastasis from a myocardium to the myocardium in a patient with a malignancy. This is another near Aunt Minnie. This disease, it does the same thing in the kidney. You see this diffuse thickening all along the border of the right atrium. The mass is completely surrounding the right atrium. You look on pre and post gadolinium images, static images. This is Burkitt's lymphoma. It has this characteristic. You can have the same rind around the renal cortex. It tends to encase organs and it acts very poorly. Speaking of acting poorly, this is an acting poorly mass. You see a mass like this, now you know what the left ventricle looks like because you've seen it so many times. Most left ventricles don't have a 12-centimeter mass hanging off of them. This is a myocardial sarcoma. So you're able to make these diagnoses that, were just laundry list of diagnoses by doing advanced imaging and characterizing the lesion. This is actually a cardiac case. But you look at the entire case, and you see all this mediastinal adenopathy. You see this lymph node that's along the right hilum. And you actually look at this case, there's abnormal infiltration all along the entire left ventricle. The left ventricular tract is narrowed to this tiny, tiny little orifice, which is actually the aortic valve. This is a case of cardiac sarcoid. It's mediastinal and cardiac sarcoid. So infiltrative can also affect the heart. This is actually the interesting use of my digital camera, but that's actually the patient's real aortic valve. It's rigid and infiltrated entirely with sarcoid. Another case that's completely abnormal, you look at the image and you see all these gross calcifications. You have it localized on the frontal lateral radiograph, so you know that those calcifications are in the left ventricle. You do a CT to confirm that abnormal calcifications. At this point, I think that there's a long list of differential diagnosis, but when you see all this abnormality on radiographs, you can start to think of alternative infiltrative processes, such as secondary hyperparathyroidism in this case. Pericardium is not that smart an organ. It can just calcify or fill up with fluid. I mean, that's pretty much all it can do. It can get thick, I guess, also, and have a mass in it. You look at this. Now, remember the other case where I showed you that the apex of the heart was over the stomach and over the spleen. This is a more normal heart, but it has a calcification in the left ventricle. This is probably not a left ventricular aneurysm because the heart is completely normal. You do the CT in this case, you see the calcification along the pericardium, not the myocardium. This is a patient that has a healed viral pericarditis. The other way that the pericardium can calcify is patients who have had radiation therapy. You can have these thick, chunky calcifications, or you can have these kind of thin, wispy calcifications. They're common in patients who have had radiotherapy, and you see them on the plain film, and you see them on advanced modalities. 40 with lupus, baseline chest x-ray, another pericardial case. This is the classic water bottle sign. You see this gigantic water bottle appearing heart. It would be very difficult to get this much cardiomegaly without having fluid in the pericardium. The myocardium doesn't enlarge that way, in that fashion. This is another pericardial case. In this case, this is a cine steady state 3% image. You see this patient's had surgery before. This is a so-called spade, S-P-A-D-E, like the playing card, spade-shaped right ventricle. When you see that spade-shaped right ventricle and gigantic atria on both sides, you can start to think about a constrictive disease. This is a inversion recovery static image, and this black line is this fibrous, dark pericardium. This is about a 7 millimeter thick pericardium. A normal pericardium should be really less than 3 millimeters, although some people will let it be 3 millimeters. This is pericardial thickening causing a constrictive process in the heart. Again, starting with the radiographs and going to advanced modalities, you can really make these diagnoses. Patient chest pain, you look at this, and again, just think about before when I showed you that pink line. Think about what normal is. There's plenty on this image that's not normal. Like this entire part of the image is not normal. This patient's going to get a CT, but if you wanted, you could do a decubitus film. If you do a decubitus film in this diagnosis, that lesion will move. And the reason the lesion moves is because it's entirely fluid, and that's a pericardial cyst. So you're able to make the diagnosis, first finding the abnormality on the plain radiograph, and then using some advanced modality to actually make the diagnosis. In terms of tumors, Mets are most common. You have a list of them here. And also remember, primary fibrous tumor, this is an example of that diagnosis. Again, it's not easy to figure out, but if you think about the pink line, there's a big contour abnormality there. You do a CT, this one's not a cyst, this one's not 4 Hounsfield. This is a solid mass, and this is an example of a benign fibrous tumor. You can't tell with the solid pericardial mass whether a lesion is benign or malignant. Do the same thing, you see this contour abnormality, this patient's definitely going to get a CT. Here the contour abnormality shows a solid mass. You see the solid mass outlined by green, and this actually turns out to be a pericardial sarcoma. So if you have a simple cyst, you can suggest that you have a pericardial, the solid mass, a little bit more difficult. Okay, acquired valvular disease, very important, also very common diagnosis. Aortic valve, mitral valve, and tricuspid and pulmonic valves, they all become diseased, they're all important to recognize. Pre and post-op patient, look at this right away and draw that line, and you see these abnormal calcifications in multiple places. This is the mitral annulus. It's below that imaginary dotted purple line. That's calcification along the mitral annulus. But that calcification is not in the mitral annulus. It's superior to the line. That's mitral calcification, and that's aortic valve. This patient has calcific aortic stenosis. They also happen to have mitral annulus calcification, but that valve that's replaced above the line is an aortic valve. Moving right along, okay? You can make this diagnosis right away. If you see the patient 7 feet tall, and that helps, and gigantic, radiographs. Before this would be on 2 films, but now with digital, you can actually shrink it all down into 1. But when you see a gigantic patient like that, with a large aneurysmal dilatation of the ascending aorta, you can shoot an angio if you want, but you don't really need to. There's a very large aortic root, and this patient has Marfan disease. A diagnosis that you can very simply make just using plain radiographs. Rheumatic heart disease typically involves aortic and mitral valves. Can produce a so-called, and it's in quotes, mitral heart. This is a great 2 words to say if you know the diagnosis. And the so-called mitral heart really occurs if the disease presents itself mostly as mitral stenosis. Rheumatic heart disease can present itself with aortic and mitral stenosis, and that's when it becomes more and more challenging. But mainly, if it presents as mainly mitral stenosis, you have the so-called mitral heart, large left atrium, left atrial. These are the plain film characteristics of the so-called mitral heart, the inapparent aorta, the large left atrium, left ventricle, the double density from the very large left atrium, and the straight carina, a very useful sign. You see it only late and severe, but you see various cases, and you're able to use that diagnosis to help you. So what looks like a complicated radiograph that you see here, you have a frontal lateral radiograph. You start to pin it down, and the first way to start to pin it down is you start to think of what would normal look like. What did this person look like a long, long time ago? And this is probably what they looked like a long, long time ago. You see the mitral valve. So you can start thinking about what's going on, and you see this double density. That's visualizing the left atrium through the heart of the lateral radiograph. You draw your imagination from that, yes, you are looking at the mitral valve. This is the left atrium. The left atrium is the most posterior. If it's projecting over the spine, it's too big. So you know that the left atrium is dramatically enlarged in this case. Also, I forgot to show you. You need a splayed carina. Now you're starting to think of the diagnosis. You can imagine what the left atrium in this patient looks like because you have this left atrial calcification. This is a patient with a mitral heart and mitral stenosis, replaced valve. Now, the degree of difficulty can be ramped up dramatically. And that's one issue. Sometimes you see a radiograph and you're just like, first you start looking up here, you know, some kind of mass, you don't know what's going on. When I looked at this, first thing I noticed was, what the heck is this? So the first thing you notice is there's this kind of lucency, it's banana-shaped lucency down there, and that's worrisome in and of itself. You see the valve, and so you start to think of the valve, and then you pick up that there's a splayed carina. So what's really going on? You got someone with a mitral valve and a splayed carina. You don't really know what that lucency is yet. It's a hard case, but you're starting to think about rheumatic heart disease. And you should hit the button in the correct way. When you do that, the CT pops up, and you start to see other diagnoses. This is what a splayed carina looks like. It's splayed. It doesn't go down. You know, it goes straight out. And then you keep looking, and you start identifying, this is the right atrium. The right atrium dramatically enlarged, and there's that gigantic left atrium. And it turns out that this banana-shaped lucency is just a piece of lung that's trapped by the world's largest left atrium. And so you have long-standing mitral and tricuspid stenosis with biatrial enlargement. When you see this much calcification on a chest radiograph, it's not really an animation. But when you see this much calcification in a patient that's had a mitral valve replaced, or a gigantic mitral valve calcification, then it does become an animating. It's metastatic lung calcifications for mitral stenosis, a good one to remember. Carcinoid heart disease, also a favorite. You need to know it. The reason it's a nice disease to remember is because it affects the tricuspid valve. And when it affects the tricuspid and the pulmonic valve, it's really the only thing in town that does that. The pulmonic valve is very rarely replaced, but it is replaced, and when it's replaced and you can identify it, that's a big benefit to you. If you look at this patient, the first thing you notice is the heart's big, so it's probably going to be some kind of heart case. And you look and you see the tricuspid valve. That's a dead giveaway that you're thinking of a patient with a carcinoid. The direction of flow of the valve. That direction of flow is from the right atrium to the right ventricle. You draw your imaginary line, and the valve replacement lies on the line. That's a big tip that your tricuspid valve, especially if you're a little concerned about here, you didn't realize that it was a little low. And this is a patient with tricuspid valve disease, tricuspid replacement. Another case looks like it's going to be complicated, but it turns out to not be so complicated because then you see a pulmonic valve. That's the right ventricular outflow tract. If you were awake 15 minutes ago and I showed you all those fancy pictures with all the colors, you know that's exactly where the right ventricular outflow tract is. That's the pulmonic valve. You have a pulmonic valve and a mitral valve together. The mitral valve is going between the left atrium and the left ventricle. It's going in that direction. The tricuspid valve right along the line, and the flow of direction of the pulmonic valve along the RVOT. This is tricuspid and pulmonic valve replacements. Patient with it, you look and you see abnormal calcification. Unfortunately, not all calcification is in valves. It usually is, though. So think about that first. This calcification actually happens to be in the patient's left anterior descending artery. And remember, other sources of calcification are coronary arteries. It turns out that radiologists now look at coronary arteries, and so you're going to have to look at coronary arteries. If you see a coronary artery, the words that come out of your mouth are cardiac-gated coronary CT or MR angiogram, depending on whether you're seeing a CT or MR. You almost certainly will be seeing a CT scan. What you're looking for is coronary plaque. Coronary plaque comes in two flavors. It can be calcified or it can be non-calcified. Those plaques that are calcified are called hard plaque. They're dense, they look like calcium. Calcium looks like calcium, you don't know where it is. Non-calcified plaques are referred to as soft or vulnerable. Vulnerable referring to the fact that they can rupture. And when they rupture, they typically cause cardiac ischemia and cardiac infarction. You also can have a combination of hard and soft plaque. Those are called complex plaques. And so a nice word to say was that you have a complex plaque with a calcified and a non-calcified component. The reason that you're looking for plaque is you're looking for stenosis. Stenosis comes in less than 50%. It's like intermediate 50 to 70% or greater than 70%. And those greater than 70% stenosis are those that are thought to be the most hemodynamically significant. This is a right coronary artery. This is actually an NPR. And it's a nice example of a complex plaque. This is contrast. It's the same IV contrast that you get for any other body part. It's going through the lumen, but the lumen is dramatically narrowed. And it's narrowed because it's a complex plaque. Hard plaque, and there's a soft plaque on both sides of this right main coronary artery. It's a cut, orthogonal cut in red along this plane, and you see a nice lumen where there's no plaque whatsoever. You take the same cut along this yellow plane, and you see a severely greater than 70% lumen narrowing. And that's due to soft plaque at this level. You don't see any calcification. This is a view of the left coronary artery. Flipped, and you see this long soft plaque. You see the luminal narrowing. This is the angiogram before and after the balloon angioplasty. Soft plaque, no calcification, causing luminal narrowing. This is a circumflex artery that corresponds to the coronary cath on the other side. I'm going to flip it over just so I can show you cross-sections through it. This is what a hard plaque looks like. It's completely calcified. There's the lumen. The stenosis there is certainly less than 50%. Calcified plaques are very often eccentrically located. That's a hard, an example of a hard plaque. You go distally to the yellow line, and you see that where there's no plaque, you have a perfectly normal lumen. So this is a normal luminogram of a circumflex coronary artery. All right, some conclusions. First of all, we went through a lot of material. Remember to send me your email. I'll give you all the notes and the slides that you're going to need. Understanding normal cardiac anatomy, no matter what modality, will help you make the diagnosis in acquired heart disease. You just need to know what normal looks like. Understand the location of the chambers, valves, and the vessels is particularly useful. What I want you to do is remember differentials, but differentials are really easy in acquired cardiac disease. You have myocardial differentials, pericardial. Also, in the valves, remember, rheumatic valve disease and carcinoid. Those are diagnoses that are common and they're important. Coronary artery disease, now you can look for plaque. You've seen plaque. It's not rocket science. You have to detect it. You detect it because there's luminal dysregularity. And the composition, soft plaque and hard plaque, and the degree of stenosis. Also, if you see a beating heart on MR, you say SYN-A steady state free procession. If you see a coronary artery, you say cardiac gated coronary CT angiogram. And also, finally, there are several cardiac NMEs. They're common diagnoses. You need to know infarct and aneurysm, lipomas, hypertrophy, and lipomas. Diagnoses you can make right off the bat. Pericardial with Marfan's and mitral and carcinoid heart. And I hope if you're going to this place that it turns out to be a walk on the beach. Next slide.
Now, for the exam, if you look at films now for the chest, just concentrate on the chest x-rays because the CTs will fall into place. The MRs, you won't really get very many of. The real chest x-ray, you've got to be able to interpret chest x-ray. It really is one of the hardest studies to interpret. The lymphoma, is it in the mediastinum, is it in the chest wall? How about exactly where it is? And then when you figure that out, look at the signs that you're going to talk about. The examiners don't want to hear, I can't see this, I can't see that. And also, try not to say the most obvious abnormality, because to you, the most obvious abnormality may be that there's a nodule in the right lower lobe and you've missed tension in the thorax on your side. So just say there is. And talk about the important positive findings and the important negative findings. And it's all about buzzwords. If you know what's going on, give the right buzzwords, the important positives, the important negatives, and then give your diagnosis. Sure, then say what you think the radiological appearance is, and then give what you think would be common sense differentials. And also for management, they like to know that if you see back to the lobe, then just to exclude an endobronchial lesion, this patient needs a D or a bronchoscopy. And when you've done that, just stop and wait. Don't go on talking, because it may be that's enough to say, and then move on to the next film. And only say what you know. If you start talking and talking, you may get into a lot of trouble. If you think you mess up a film, don't worry about it, just go on to the next one. So, let's see what we thought. This one here demonstrates volume loss in the left hemithorax with this hazy veil-like density. There's a massive lesion of the left hilar hemidiaphragm, and on the lateral view you can see this well-defined line here. This is the oblique fissure that's been pulled forward by left upper lobe collapse. Classical features of that. If you see volume loss with just a peak, think of upper collapse. You lose the left upper lobe. It's hazy increase in density, gives you a clue. They made a CT, and here you can see bulging centrally. This is the golden sign, which prevents complete collapse and shows that you've got central mass. Now, the other collapses, you really must know your lung collapses, because you're all going to get one, or one of you are going to get one definitely, and these are the ones that you need to know. Now, the left upper lobe, when it collapses forward to get that hazy veil-like density. The right upper lobe is different because it has the minor fissure, so it forms this triangular wedge density here. This is the minor fissure, this is the major fissure here, which goes past the hilum. And so this is classical right upper lobe collapse. Left lower lobe collapse, you can see a sail-like density behind the heart, pulling on the left arm. Remember, the left hilum should be either higher or at the same level as the right hilum. If it's pulled down and you don't see the basal pulmonary artery, think about if there's left lower lobe collapse. And left lower lobe collapse is posteriorly, so on the lateral view you see this increase in density here. The spine should get blacker as you go down, whiter here, and that's classical for a left lower lobe collapse. And the width of the collapse collapses into the mediastinum. There's a right lower lobe collapse. It's very similar to the left lower lobe. Top line, that's the oblique fissure. This is the cartilage collapse into the mediastinum. Here's the lateral view. And the middle lobe collapse, you really don't see loss on the PA view and loss of the right heart border. You can't tell right middle lobe collapse and right middle lobe consolidation because the lobe is small, and so in loss is difficult to appreciate on the PA view. Decide is collapse or consolidation. Look at the lateral view. This is the minor fissure, this is the major fissure or the oblique fissure, and if they're pulled in this case, that means that there's collapse. If they were wide apart as you see normally and there was space opacity within it, then that would be consolidation. So loss of the right heart border, right middle lobe pathology. The lower lobe, as you know, come off the intermediate temporis, so sometimes you can get a lesion in the intermediate temporis. And this is different because you've lost the right heart border, you've also lost the hemidiaphragm. And this line here, the line goes all the way across to the lateral border. And on the lateral view, you can see this is the line, is it the lower lobe, which is with the middle lobe, which is anteriorly. So that's combined collapse. Okay, the second case, you can see no evidence of volume loss. So there's no evidence of collapse, but there is evidence of space opacity. There are convolute nodules here, which have air grams within them and loss of the vessel outline. So this is classical airspace opacity or consolidation. And in the exam, now this patient actually had tuberculosis. It was upper lobe disease, but you may not. So you need to think about the causes of airspace disease. And the reason you get airspace disease, acini is being replaced. It's being replaced by fluid, different types. So when you're sitting about all the ways that you can replace fluid. So it could be due to edema, cardiogenic direct pulmonary edema. The air could be replaced by fluid from infection. This was TB, but any. It could be blood within the air spaces, so this could be due to hemorrhage, pulmonary hemorrhage, could be contusion, trauma, could be a pulmonary infarct. Or the aggregate tumor, so if you see consolidation, if you know it's chronic, think BAC, lymphoma. And there are the weird things that commonly come up in exams, so pulmonary alveolar proteinosis, sarcoid, we saw this morning, alveolar disease, vagus, amyloid, eosinophils, and organized pneumonia. Okay, next case. Now, this one might start a bit sweaty when you're sitting in that hotel room and you really don't see anything. Maybe some of you did see something. The abnormality. If you look down, this is the descending thoracic aorta. You should see the descending thoracic aorta all the way down behind the heart, but you actually lose the line of the descending thoracic aorta here. You also lose the hilum, so there's a lobulated mass here. You lose the vessels. You should be able to see the vessels behind the heart, but you do. And on the lateral view, look at the spot, blacker. It's white here. So this is it looks quite subtle on here, but on the CT scan, it's really quite large. So one of the things, sitting in the room and you don't see anything, remember your review areas. And everyone should have a systematic way of looking at review areas. The way I do it is up to you if you want to use this, but I actually start in the neck and then I work my way down. So I start in the neck, I look at the trachea and the airways, and then I go to the apex. That's where we miss masses because there's confluence of those. And then as you're coming to the mediastinum, you know that the mediastinum should be smooth, you know that the line should be 5 millimeters in the right paratracheum, more than a centimeter in the region of the azygous vein. You should see the aortic arch clearly, you should see this AP window, you should see a nice smooth outline here of the left heart border, follow the right heart border. And as you come down, look along and look behind the heart, you should be able to see the vessels. No, you don't see the vessels here. And then as you come down to the diaphragm, look at the shape of the diaphragm, come below the diaphragm because the lower lobes extend below the diaphragm. So you still haven't seen anything, go laterally, go to the costophrenic angles on both sides, and then work your way up, look at the ribs, look at the soft tissues. And as you're looking up, just look at the lungs, look for symmetry on both sides, and then work your way up to the clavicles. Anything then you haven't seen anything, but that was that cancer. This one, again, looking at it, you're not quite sure what it is. Do the same thing again, go through your review areas, and this one, female patient. If you say female patient, is there a breast shadow on both sides, okay? So breast shadow here, no breast shadow, and mastectomy with that axillary node dissection. Relatively normal chest x-ray, these are the things that should go through your head. Has the patient mastectomy? Do I see a stomach bubble? The stomach bubble's missing, you start thinking, like, the chest x-ray looks normal, where's the aortic arch? Right side aortic arch is very notorious in exams, and they can be difficult if you don't think about them. And look at the trachea. The trachea is shifted to the left, think about a right side aortic arch. Another difficult case, if you really don't see this, is their inferior notching. Still haven't seen anything with small pneumothorax. And then just lungs. Am I missing ground glass opacity, such as PCP? So this one, again, looks difficult. I don't know what's going on here, but if you look carefully, look for symmetry, and you see that this side is darker than this side. There's an abnormality in the lungs. Well, the lungs look pretty good, actually. It's the whole of this darker, and this is a unilateral loosened hemithorax. And see that the cause for this on the CT scan is because of absence of the pectoralis muscle. This was a patient who had Poland syndrome, but the other cause of a unilateral hypollucent lung or a hypollucent hemithorax that would be technical, so it could be rotation, it could be a testicle defect. We've seen Poland's, we saw the mastectomy. It could be due to decreased vascular perfusion, so a patient who's got a congenital cause such as pulmonary hyperplasia or an acquired cause such as massive pulmonary embolus, you'd see a hypollucent hemithorax. Or there could be overexpansion of the opposite lung. Overexpansion of that lung, for example, patients with emphysema or inhaled thrombody in a child, or it could be due to increased capacity of the other lung. Okay, next case. So this one, every time I look at this one, I can't remember what the cause is, but if you look down, you can see that there's actually rib notching. So one of those cases where you really don't know what's going on, so just start thinking about what I'm missing, and that's one of the ones that you could always think about. And this was a patient who on MR had a beautiful coarctation. You really couldn't pick that up on the chest X-ray, but you may just pick up the rib notching. So rib notching palpation is usually the fourth next, and you know that's because of hyperplasia of the internal mammary arteries. And on chest X-ray, they said it usually prominent ascending aorta with a small descending aorta and an intervening notch. Well, we didn't really see that. We saw the rib notching. So the other causes of inferior rib notching include coarctation, if it's unilateral, a post-operative Blaylock-Tarsic shunt, and then any cause of obstruction to the normal vessels, because that causes enlargement of the enlargement of the internal mammary vessels. So aortic thrombosis, pulmonary oligemia of any cause. SVC obstruction will cause laterals, which can cause inferior rib notching, and then AVMs can cause rib notching, neurofibromatosis as part of the rib dysplasia. Okay, next case. This is one of those ones where you need to have seen a couple to recognize this. This is a small hemithorax on this side, and if you look at the vessel here, this is abnormal, okay? This is a scimitar syndrome. This is a CT. You can see the scimitar vein as it's coming down, and this is the coronal and sagittal reform. It shows why you see that abnormal curvy vessel, which resembles scimitar. But note also that the hemithorax is small, and it's not just a scimitar. This is a systemic disorder of the whole lung. It's also known as hypogenetic lung syndrome, because you get an ipsilateral small hemithorax with pulmonary hyperplasia. The bronchi are reduced in number and in size, and the vascular structures are reduced. It's always right-sided. And the scimitar is due to this enormous pulmonary vein, which drains the LUC, as we saw that, associated with septal defects. Okay, this case now, in a normal reporting pile, you're going to call this consolidation 100 times over, probably pneumonia, but in the board exams, young patient, you see consolidation with maybe cavities in the lower lobes. CT scan demonstrate there are cavities in the lung, so you know the pathology is in the lung. And the reason I gave this is the contrast-enhanced scan, you can see it's a little vessel coming off the aorta. So this is pulmonary sequestration. If you have a young patient with recurrent pneumonias and a lower lobe mass or a left posterior mediastinal mass, always think of sequestration. And the diagnosis requires demonstration of a systemic blood supply. That's what you're going to say in the board exams. Types the intralobar will drain to the pulmonary veins, the extralobar drains to the systemic veins, and infection is common with the intralobar, which is what this case was. All right, next case. Side marker, heart, stomach bubble. All right, so this is dextrocardia with situs inversus, and then if you look carefully on the K and lateral views, you can see that there's bronchiectasis. Right? Tubular, dilated bronchi running down. So this is a case which on CT showed the situs inversus very nicely. This is the liver spleen opposite sides as well. And this is the bronchiectasis with the dilated bronchi between the blood capacities. And this is Cartaginous syndrome. So it comes up commonly in exams, and these are the findings: bronchiectasis, situs inversus. They have sinusitis and male infertility. Aren't many. Very dense nodules, really so denser than the bone. In fact, they're so dense that they make the pleura black. This is the black pleura sign with dense calcified nodules. And this is an many of alveolar microlithiasis. We saw this example this morning. And the differential diagnosis when you see such dense, tiny causes: metastatic calcification in hyperparathyroidism, aspiration of barium, recent lymphangiograph, and that's about it really. Okay, so this patient here looks like there's increased air space opacity, both sides, but the higher SCT really helps you. This shows geographical distribution of ground glass opacity with this septal thickening, giving it a crazy paving appearance, and this is characteristic of pulmonary alveoproteinosis. But if you just picked up the ground glass opacity, you could talk to the examiner about that. The ways to divide up ground glass opacity are really acute and chronic. If the examiner tells you it's acute finding, then the things like pulmonary edema, infection, especially PCP, then pulmonary hemorrhage, think about SLE, good pastures. Aspiration can also cause ground glass. Whereas if this is long-term ground glass opacity, then the other think about a hypersensitivity pneumonitis, malignancy, especially BHC, and then all the forms of interstitial pneumonia, so UIP, DIP, etc. This one here, rib fractures. Well, he's not going to show you rib fractures. Clavicles, all right? Erosion of the lateral ends of the clavicles here. And then if you look more carefully, there's abnormality within both humeral heads with erosions and destruction. And there's a differential for erosion of the lateral ends of the clavicles. But this one had all other features to suggest that it was rheumatoid arthritis. But the other causes that you talk about, post-traumatic osteolysis, so if the patient is a weightlifter, then they can just have osteolysis of the lateral ends of their clavicles. You may see other signs of hyperparathyroidism. We had a talk this afternoon on all those findings. So look for other findings that may give you the diagnosis. And that's the important thing. In the board exams, you find one thing, keep looking around while you're talking to try to get the complete diagnosis. And then other causes of metastatic disease, multiple myeloma. And in a younger patient, think these clavicranial dysostosis and pigmentocytosis. All right, so this patient, again, really don't see very much. One of the things that you should remember are the lines on a chest X-ray. The biparatracheal stripe should be 5 millimeters or less. As I said, when you go down to the azygos, it should be 1 centimeter or less. The aortic arch should be seen clearly, the descending thoracic aorta should be seen clearly, the vertebral line should be no more than a centimeter on the left, 5 millimeters on the right. And as you go down, you can see that there's a paravertebral abnormality here. There's an enlargement of the paravertebral stripe, both sides. And if you look carefully at the spine, maybe hard from where you are, but you can see there's irregularity at this level. And this patient actually had destruction of the end plates here. This is the paravertebral abnormality that you see more clearly on this over-penetrated view. And on the CT scan, you can see destruction, paravertebral lesions. This was TB, it's fine, but anything that sits in the posterior mediastinum can cause abnormalities. So neurogenic causes, lymphadenopathy. Don't forget foregut duplication. Cystitis hernia is probably the commonest thing we see on a chest X-ray. But esophageal masses, and then aortic aneurysms, hematomas if the patient's had a history of trauma, and then the usual things that keep coming towards. Alright, so this one, what do you see? Well, the abnormality is in the region of the hilar, and what's wrong with the hilar? They're bilaterally dense, they're symmetrical, but they're big. And if you look at the shape of them, they are tapering, so they are following the shape of the pulmonary arteries. And then you look at the vessels distally, they just taper off very quickly here. This is peripheral pruning. And loss of the vessels peripherally, massive enlarged pulmonary arteries. So this is pulmonary artery hypertension. See the lateral view, and then on the CT scan you can see calcification of these enlarged pulmonary arteries, and on windows you can see how tiny the peripheral pulmonary arterial supply is. Pulmonary artery hypertension, again, is one that's common in exams, and these are the causes. So primary artery hypertension, and then increased blood flow from shunts. We saw these in the pediatric cardiac talk yesterday. Anything that causes a left or shunt will initially cause pulmonary plethora. And then pulmonary vascular resistance will increase, the patient will develop Eisenmenger syndrome, and they'll develop those changes of pulmonary artery hypertension. Or it could be secondary pulmonary artery hypertension. So the commonest thing that it's usually secondary to is lung disease. So patients who have emphysema, fibrosis, bronchiectasis, they get secondary pulmonary artery hypertension. It could be very large patients who have hyperventilation syndromes, or it could be due to pulmonary venous drainage disorders or arterial diseases. So in patients with chronic pulmonary embolus, they'll get pulmonary artery hypertension. Pulmonary venous drainage, well, pulmonary veno-occlusive diseases, and also patients who have chronic mitral stenosis, because mitral stenosis causes pulmonary hypertension, and then black flow leads to pulmonary arterial hypertension. Alright, so this one, again, big hilar, bilateral symmetrical hilar, but now they don't have their normal hilar very related. Alright, this is lymphadenopathy within the hilar, and then causes lymphadenopathy, you'll know, this is the CT scan which confirms these bilateral lymph nodes extending not only into the hilar, but into the spinal space as well. And the differential diagnosis, this was a case of sarcoid, but no of the top three differentials really. You've got sarcoid, lymphoma, infection, lymphoma metastatic disease you can throw together. But TB, don't forget TB, especially in a patient who's going to be HIV positive with TB. And the usual causes, if the examiner doesn't take down the film, then think of the rarer causes. And these things often come up: Castleman's disease, topical anthracycline drugs if the patient's on phenytoin or methotrexate. But try and remember the top three every time you look at something. This is just another case of sarcoid, and it just shows the other places where you can see lymphadenopathy. And these are the CT scans which correspond to these levels. So you can see that there's paratracheal lymphadenopathy. This is greater than 5 millimeters. Here we're down to the vein, greater than 1 centimeter. So this is this region here. The aortic arch, you don't see it clearly. It's the notch where the aortopulmonary notch should be, and that's because of this lymphadenopathy, the prevascular region, and then the aortopulmonary window. And then sometimes you can see this line here. This is the azygoesophageal recess, and you should be able to follow this all the way up to where it drains into the SVC. This is the line of the azygos and the esophagus. But if you